So hi everyone. Okay. So hi everyone. My name is Zainab, and I'm a PhD student at the Commissary Lab with Dr. Pinero. So I will be adapting, translating, and validating a patient-reported experience measure that was developed at the Great Ormond Street Hospital in London, UK. So this is the instrument that was developed. This version is for 8 to 11-year-old. So the instrument really asks for objective experiences of the patient, and patient experiences, as you know, are important for the quality and the service improvement of the care that children receive. These are also some of the snapshots of the PREM instrument for 12 to 13-year-old and from the 14 to 16-year-old version. So the research question that we're really asking is, how can we adapt, translate, and validate this existing PREM CYP GOSH instrument to the Montreal Children's Hospital? So my objectives are, one, to create a reliable PREM CYP tool for the Montreal Children's Hospital, and then to achieve a twofold validation of the PREM CYP Montreal, the adapted tool. So it's important to talk about patient-reported experiences because they're valuable markers in healthcare. They evaluate the objective perception of experiences rather than the subjective perceptions, and they also reflect on the quality of care. They're feasible and also time effective. So PREMs are useful in public reporting, benchmarking of institutions, and also important in creating healthcare plans. They improve wait times, so communication, team coordination, all of PREM data actually. They can also provide patients in designing, managing, and policymaking of healthcare services. So the participants that we really are focusing on are children and young people. The age eligibility is 8 to 16 years. They will be selected based on language and attending a pediatric surgery clinic. So this is the data collection methods. We have phase 1. The first step we're in right now actually is the think aloud testing. Basically here we're asking children to read a few questions from their designated age appropriate questionnaire. We ask them to read it and just basically, whatever they're thinking, just tell us what they're thinking, and we're recording it and noting down anything that they, which questions are good, which questions are not good. And then basically for step 2, we're going to revise that version, whatever from their input of the question, the question, if the the appropriateness of the question, we're going to revise the instrument, and then we're going to do a cognitive testing with the same children or with different children. So that would be phase 1, and then for phase 2, we're going to use that adapted questionnaire, and we're going to translate it into French. Once we translate it, we're going to verify it and revise it with our research team, and then we're going to test it with the French kids. And then for phase 3, we're going to have basically, this is going to be the validation phase. So we're going to have a group of children and young people, CYP, and there's going to be 12 to 15 participants. First, we're going to give them the French instrument, and then we're going to tell them to fill it out. And then we're going to give them a 5-minute distractor, and then we're going to give them the English version of the questionnaire. And we're basically going to tell them to fill it out as well. And then we'll take it back and we'll ask them a few questions. How it was it similar? Did the question ask the same thing in each language? So so for phase 1, we're really looking at English-speaking children. For phase 2 is going to be French-speaking. And then phase 3, bilingual, where children are going to be fluent in English and also in French. So all the steps in phases 1 and 2 will include different children. In phase 3, there's going to be the same group of children that are going to be given the French and English version of the PREM CYP Montreal. For the analyses, it's going to be all qualitative except in phase 3. So for phase 1 and 2, we're really looking at qualitative coding, thematic analysis, grouping similar themes that we identify from the children's input and basing our selection of the questions on that. And then phase 3 is really inter-rater reliability, where we're going to use the intra-class correlation coefficient, which basically reflects, so intra-rater reliability really reflects the variation, which is measured by one rater across 2 or more trials, and we'll calculate it using two-way random effects. And this is the project timeline. So for phase 1, well, we anticipated September, but we started it in November. So we're adapting the English instrument. By February, hopefully we'll have all the steps done for phase 1, and we'll start our phase 2, where we'll translate the adapted English version to French. And then we'll start the phase 3 of validating both instruments. So we're really trying to give children and young people a voice. As you know, there's limited data actually available, and not a standard questionnaire that's been developed for the Montreal Children's Hospital. So it's really going to be the first one that's going to be developed for our hospital. And we want to increase the acceptability of generalized data over a larger population, and we want to ensure instrument compatibility with the CYP population of Montreal. Thank you so much.
Sorry, I kind of curious because I thought you said something, Nancy Mayo, and qualitative stuff. So I Googled her because maybe this project also has a qualitative component. That's why I kind of put it in the notes there. Sorry about that. So without further ado, my name is Mohamed Elahmedi. I am supervised by Dr. Dan Poinerou. We are working on a pilot study that evaluates, that evaluates children's journey. This is a digital health application that's involved in personalized communication with our patients. And the reason for this app is an observation that healthcare is plagued by 3 major problems. These are healthcare provider bottlenecks, which include time constraints, availability, and waiting lists and stuff like that. And also ineffective communication and limited information retention. Don't forget that most of our interactions with patients are in clinics, and generally speaking, you only have 15 minutes to talk to your patient, I guess. So these 3 problems cause anxiety on a patient and parent level. It does cause increased health service utilization because confused patients will come back to you to an ER or to the OPD in an unscheduled visit or a phone call. And it's also leads to reduced quality of care. And it's true because when we at Commissar Lab asked families of children undergoing surgery, they told us that they highly valued functional and quality of life outcomes. And they also identified post-op instructions, follow-up, and communication with the healthcare team as most lacking in their care. And this is serious because communication is central, or effective communication in this case, is central to positive health behaviors, adherence to recommendation, and also for patient safety. And for this reason, the Commissar Lab developed an AI-powered mobile app that accompanies and empowers children and their families before, during, and after their care at the Children's Hospital. But before this app is deployed or implemented, I think we have to ask ourselves 2 very important questions. Is this app going to reduce utilization of hospital services? And is it going to help patients have a better experience? Because when you look at other sectors, the banking industry, for instance, once the banking industry started to leverage technology in communication, banks observed lower costs and lower utilization rates. But as customers, it kind of wasn't a very smooth experience, honestly.
If you would like to set up a new...
I don't think we have time for this, by the way, while going through it. Maybe next time. Sorry about that. So the objectives of the study are to evaluate the effect of the app on utilization of hospital services, and also to evaluate the experience of families who use the app compared to those who don't, or compared to those who receive standard of care. And the methods, or the way to do this, the way we're doing this is that we're developing, or we're doing basically a mixed method study. So there's a quantitative component and a qualitative component. Sorry about the typo there. It's also a cluster randomized study that aims to prove clinical superiority with regards to health resource utilization. But the reason for having a qualitative component is that we're studying patient experience and probably emotions, which are rather more subjective or abstract concepts that can't really put a number to. And also quantitative, and the quantitative section is because there's health resource utilization metrics, and there's also quality of life. With regards to this being a cluster randomized trial, instead of an individual or patient-level randomization, the reason for this is that clusters or randomizing on a cluster level avoids contamination. So if you're deploying an app to a certain department, it would be hard to give it to certain patients and not to other ones, right? And there's also convenience and the fact that an intervention such as an app is better delivered to groups of patients. Anyhow, a cluster in our trial is defined as an individual half-day pediatric surgery outpatient clinic. And an intercluster correlation coefficient of 0.03 will be used for our purpose. We've also, and for our clinical superiority null hypothesis, this is a hypothesis that using the app is not associated with more than 25% reduction in health resource utilization. The study population, obviously, we're going to include children who have planned inguinal hernia or hydrocele repair, who are accompanied by at least one parent. We will have to exclude parents who are unable to communicate in French or English, and parents or families with no access to a smartphone and a stable internet connection. For the present phase, we are going to be starting with a pilot study, which aims to recruit at least one participant from each of 4 clusters. The aim of this pilot study is to inform the feasibility of the project. And we aim to start the project on early next year. Data sources for this project, well, there are many, but basically you have OASIS for healthcare utilization metrics, such as frequency and number of emergency department visits and unscheduled outpatient department visits and stuff like that. We also have questionnaires, which include the Pediatric Quality of Life Questionnaire and the PEQP, which is Patient Experience Questionnaire for parents of pediatric patients. Qualitative data will include a parent diary, a parent 30 to 60-minute interview, healthcare provider logs, and healthcare provider 10-minute interview. Data analysis, basically quantitative and qualitative analysis are different. So for quantitative analysis, we will be focusing mostly on reporting effect sizes and 95% confidence intervals. For qualitative analysis, we will be using a phenomenological approach, which captures the lived experience of a participant as they go through the process. We will also be using a collective case study framework in which we look at patients and try to find a broad or a common objectives or common themes between them. This will all feed into thematic network analysis, which is basically an effort, or basically we search the data and we select or generate basic themes, and then we group those basic themes together under common organizing themes, which all in the end feed into a global theme. The RAB, MUHC RAB is going to review the study and is responsible for monitoring it. For knowledge translation, we are in the process of creating a knowledge translation plan, but we could identify several stakeholders who will be involved from idea formulation or from after idea formulation, or some stakeholders will be involved at the end of the project once we disseminate it, or even beyond the end of the project. And yes, thank you for listening. That's it.